Yeah, I'm going to go old school and just click on the buttons, right? So as an implementation scientist, I'm a professor of AI, but specifically implementable AI. I really appreciated that talk. If really computation is the new oil, then I feel that implementation is the fire. And what point is oil without fire, right? So I just want to start this right now just to thank you for the opportunity for us to present our work here, and not just to present our work, but also to provide us with the resources to actually have executed it. We really take this seriously, and we want to make this opportunity something that is a public good, and to do it at scale. And so the talk here is called Massive Online Open Validation and Evaluation, MOVE. It's basically an initiative to make foundation models for clinical practice and to do it at scale, and also to evaluate them at scale as well as implement them. And there's a lot that can be said by the word massive, the first one there. It is a very big initiative. It includes many, many students, many institutions. It includes many researchers, and also many, many humanitarian actors and doctors from around the world. From Zanzibar to Peru to Lausanne, this kind of scale can only be possible with access to computing resources like the Alps. I think it's a really good example of what can be possible when we do have access to these kinds of centralized computing resources. And we're very grateful. So what are we doing with it? My lab that we're running, it's called LIGHT, the Laboratory for Intelligent Global Health and Humanitarian Response Technologies. And as I said before, we're really interested in implementable digital global health. And if you're implementing a learning system, you have to be involved in the entire process of how this learns. So from data collection, which is basically trying to take AI models and implement them in very low resource and challenging and also volatile and dangerous environments, collecting data in those settings is extremely important. It's difficult and often neglected in low-resource settings. One of the things that are missing, and we're running out of data, as you heard, but especially in low-resource settings, is data. It's also very important that we focus on the ethical management of that data, especially important when we are dealing with a centralized computing resource. We have to make an intentional effort to decolonize the ownership of data and to make sure that we can maintain local ownership when it is collected. We then make AI models, but it's a whole lot of different kinds. So, multimodal models, of course, large language models and large multimodal models, and interpretable models as well. But the difference here is that we really make them user-based and needs-based and with a user-centered design. And we are working with partners at ICRC, like the International Committee for the Red Cross and Doctors Without Borders, and our other actors to guide us in which models they want. And when they do end up working, right, then we try to close that gap in the implementable pipeline and put them into an application, and then take it back into the field and do randomized control trials. And the learning cycle continues. So, why do this here? This is where I work. I'm also a medical doctor, and I'm volunteering in mostly humanitarian and low-resource settings back in my home country of South Africa. And lots of people are asking me, well, why do you do these complex models in such low-resource settings where there's hardly electricity and running water? And these are photos that I took just outside the hospitals that I'm volunteering in. So why make tech here? Don't these places need simple solutions? Don't they need stepping stones to get to the point of managing this technology? It couldn't be further from the truth. In fact, we don't need to buy a fax machine to understand how to use a smartphone, right? And this kind of leapfrogging of technology, that's what makes something revolutionary. That makes a fantastic change from a status quo that is completely unacceptable. People die of preventable deaths here that are completely unnecessary. Tuberculosis, ridiculous way to die. It's just completely unacceptable. And about 80% of our patients have it in our hospital. So, also something that's interesting here is that people think, well, let's not make technology here. Let's also just we can't use it afterwards in a high resource setting because here we'd have to cut corners and the quality will be lower. Again, a myth, because here, there are no safety nets for these patients. If you get something wrong, there's going to be consequences. And so we actually have to follow the highest standards and be as robust as possible to the volatility, which actually makes the things that we are making very applicable in some of the highest resource settings that I also worked in right here in Switzerland. And that's why this is an international initiative that attracts both doctors from the highest resource settings as well as the lowest resource settings, which creates this scale. And even if the impact can be very, very significant in both high and low resource settings, we do have to acknowledge the obvious conclusion that when we are taking massive resources and filling a massive resource gap, obviously the size of the impact is going to be disproportionately in the places that need it most. This is the concept of equity, right? So we can make the same model in concept, in principle, but will have obviously a much higher effect in some of the lowest resource settings. So what you're seeing here is a map, and it shows the number of physicians per 100 or 10,000 population. So in Switzerland and Europe, we're comfortably with about over 40 physicians per 10,000. And in the continent of Africa, less than one. Less than one. So it's not only high impact, but it's also reducing the trade-off that we have to make. You often have heard this argument about, well, you know, we're making these tools and they may replace radiologists or may replace doctors, and it's this trade-off, is it worth it? Well, you can't replace a doctor that doesn't exist. And so you're not only making a higher impact, but you're also reducing the cost of the tool if you implement it in the right place. This is where automation is needed. It's needed to actually implement basic human rights and human care. It's so important. And just to show you a little bit of like the human side of this, we can maybe zoom into one of the hospitals where I volunteer in South Africa. It's a rural environment. And here we see Mama Gabby. And Mama Gabby was found outside our hospital about 1 kilometer away, and she braved the pavements and sidewalks of this rural environment. And it's very difficult, and it's muddy and rocky and uncomfortable in her makeshift wheelchair. And she joined a queue, and then she fell asleep because she was so tired after staying months and months at home, avoiding to go to the hospital because she was too sick and too difficult to get there. Access is difficult in low resource settings. It's difficult for many, many reasons. And that's why simple things like telemedicine and decentralization of care is transformative. Imagine if Mama Gabby had on her smartphone, which she does own, the information that she needed. It could have changed her entire course, and she wouldn't have to have sat in the sun the whole day and dehydrated and been on the verge of death by the time she got care in the hospital. And let's not forget that her journey wasn't really represented. What model could we have placed for her there? Every place is different, and some places are more different than others. We would have to do the same thing in Switzerland to differentiate ourselves from the US. It's a very different healthcare system, and thank goodness for that. And here we have a different kind of care pathway. The WHO, for instance, a few years ago, estimated that over 80% of the population of the African continent first seeks care at a traditional healer before coming to our hospitals. And what does this look like? Well, it sometimes delays care, but it can also completely change the predictive symptomology of how our patients present. So here, for example, these are two places where I was volunteering in South Africa and in Cameroon. And these are herbs that people use to cure things. There's a whole lot of things here that's going from typhoid to some strange things as well that I've never heard of as a doctor, like worms of the woman. I still don't know what that means. But we can find it as kind of far removed as we like from reality. But it's a very reasonable choice to make when the alternative is sitting in this queue all day until you reach Mama Gabby a kilometer away. And so it's very reasonable to make these decisions, but it also changes the course of the patient's representation. Those are all mostly laxatives that you saw there. And it means that our patients come to our hospitals with dehydration and diarrhea that simply means something different than in a different setting. So we do have to represent these situations, and we have to contextualize our models in every single place, whether it is in a low resource setting or in a high resource setting. But something that is kind of cross-cutting across everything. If you are a doctor, you know the one thing that is determining health the most is information. Information is a determinant of health. It's the ultimate determinant of health. And there's bad information out there. And everyone has their own conspiracy theories, but this is genuinely a flyer that I got at a traffic light of a person who claims to be Dr. Rashid. And he is offering all sorts of services from chasing away demons, and we can think that this is all tongue-in-cheek and silly. This is a real service. And it gets very sinister when you actually see some things. Well, number 16, Dr. Rashid is not very good at formatting his documents. There's two number 16s. But the first number 16 there is actually offering services to HIV-positive patients. And this means that they may not take their own medication. And so everyone has their own conspiracy theories. Here it might be something about vaccines or something else. But we have to represent that and get better information. And there's nothing more powerful than the right information at the right time and in the right place. And this is why we are making large language models and large multimodal models and large multimodal multilingual models so that people can have the access to the information that they need at the time that they need it. And this is why we made Meditron. So Meditron is a suite of these open source models. And we, as I said, try to make it multimodal and multilingual. And that's one of the things that we are working on at the moment. But what sets it apart is that it's co-designed with the users, the clinicians that are using them in each of these contexts, which is why we are scaling it. And it's adapted not only to high-resource settings, but also to low-resource settings in humanitarian response environments. So how did we do this? It's quite straightforward. It's just large. So we take Meta's Llama model that was recently released, and just for some fun, interesting facts, it was trained, the 3.1 that was released recently, with 11 trillion words. That's about equivalent to 180 million books. And if we actually wanted to read this ourselves, right, it would take, at an average reading rate of 200 words per minute, it would take us 110,000 years to read what has been condensed into one of these models. It's an enormous amount of compute, and there were several that were released, and hopefully there will be more. And for whatever reason, they released it, obviously to, not necessarily being a humanitarian organization. We are very grateful because we can use that as a foundation for our own models, where we do continued pre-training. We've done it at a smaller scale, and now we are stepping up. And this is what we have been busy doing on the CSCS cluster. So we take the latest research that's been carefully curated by our doctor cohort from across the world, and we take millions of guidelines that they have also curated as well, and put this into the model for continued pre-training. We make several models like Meditron 70 and 8 billion parameters, etc. And then we also make it multimodal by taking image data as well as sound now. We're taking ECGs, time series, quite a lot of different models that is naturally extensible. And we can now take that information and put it into the model just as you put in words and make multimodal implementations of these tools. So we're very proud that, of course, when you take at least the latest version of our LLM that's not multimodal, on all of the standard benchmarks of medicine, which are these USMLE exams. Ooh, those are difficult, right? Super difficult exams that would take me months to prepare for it. Even though I am a doctor, I would still have to re-prepare. And actually, the average pass rate of a human is 60%, right? And our models are getting, it's better than so far OpenAI and Google and Meta on these benchmarks, and we're getting about 80% on these tests. But when last have you seen a patient coming to you going, doctor, I've got chest pain, and it could be A, B, C, or D, right? This is not how reality works. And these benchmarks are not representing our reality. And so we have to ask harder questions, and we have to ask realistic questions, and we have to implement the tools to see if they actually work. So we must remember that that's not only the only problem with benchmarks. You can't just ask better questions in the comfort of your home, because as soon as you release them, you're subject to Goodhart's law, right? Which is when a measure becomes a target, it ceases to be a good measure. People hack them, and we've seen that in multiple occasions. They become static and generic and out of date. They're oversimplified and they're hypothetical. and they're just simply not implementable. So we did ask our model harder questions, and one of the first iterations we found with medical accuracy, interpretation, safety, fairness, and communication, doctors really liked it. All the dark stuff is good, right? So about 80% scoring well on these metrics. And this is kind of the adversarial testing that we're trying to formalize in the move. So we also asked it, of course, just some fun questions like, if Meditron was a human, what kind of human would it be? And no one said that it was a layman or a medical student. Only a few said a new doctor, and the rest all said a doctor with 1 to 5 years of experience or more. And even a few said a medical oracle like Dr. House, right? So clearly, there's use for these models, even when they are very small and outcompeting these other big models. And so if we formalize this, this is what the move is about. It's about having locally owned community alignment, having evaluations that match the way that you're going to implement the model. It's about having expert validation and to use that validation to co-create the tools with the people who are going to use it. It's about having continuous learning and to include this in your computational cost, the dynamic and updatable nature of the models that you're going to learn from. It's about making them accountable and ensuring that you have transparent oversight and real leaderboards that can compare models and their claims. And it's about having adaptive and representative evaluations that are relative to each of the conditions that you are going to implement them in. So it's a website, basically. And you can see here how it works. It's a collaborative platform where doctors can share their expertise to align AI with real-world medical standards, not just medical. We have a few others as well. You've already heard about this, transparent, community-driven expert validation that goes beyond accuracy. And we have Meditron on there, but also many others, so that we can do a head-to-head comparison. And we are going to make this global library with all of our partners, with the WHO that will also be acting as a clearinghouse of the tools in the end. And so we gamify it. You can see here you can earn some points. You challenge the model with tough questions. You correct them, right? It's not to infantilize it. We need to tell them that they can't just do it once and congratulate themselves. They have to do it often. And they share their guidelines, and we can use that. And they can get the points then, and it's theirs. They can publish it. They can say, Meditron is terrible in this setting. And they should do that. And then we can use that and actually feed it back into the model and give them their own customized model to make a zoo of models that are representative. Looks just like ChatGPT. And you can type in, here's a conspiracy theory that we're trying to test it with. Does MMR vaccine cause autism? We don't know if the base model that it was learned from, the llama, actually contains this conspiracy theory, so we have to check, which is why we're very excited about the work that Martin Yagi will be doing to hopefully train a model from scratch with data that we can actually see that's transparent. It comes up with an answer that looks pretty good. It completely refutes it, gives some scientific evidence, risks of not vaccinating, looking pretty good. It's got a summary, and we're pretty happy with it because it really, at the top, it really doubles down as well and says, this is absolutely and thoroughly debunked. So that's great. You can see that there's two answers. And what we're doing here is we're taking Meditron, and then we take this answer, put it back into Meditron, and say, give me a second opinion. And we look at this one, and it's a little bit less convincing to me. So what we have to do now is choose, just like you do on ChatGPT, and you choose which one is your preference. And here the preference is going to be, let's say, this one on the side, and I take that. And with that, I can already improve the model. That is the base, and I can also make a leaderboard. I can say then why it's better and why that one is worse. And this granular kind of feedback that we get can also make a parameterized version of the better model to understand why these parameters that we are choosing here are better or worse. So I'll skip through it because there's quite a lot of other things on the platform, but I'll skip through that so that you can just rather look at what we're doing next, which is taking this initiative to make a whole lot of models and implementing them. We are implementing this at scale across 5 countries in Southern Africa, but also in Africa in general, and then also in Switzerland as well. So what we do here is we take this model, and we take patients, and we either let them have a doctor with Meditron or without it. And then we let them ask the model questions during the consultation, with or without that tool, and then follow the patient up later to see the outcome of the patient's care. And this is really important because then we can actually understand something that goes way beyond accuracy, which is safety. And it's important that our models actually represent how we're going to use that, and we can take that safety and the true diagnosis to make models, making a leaderboard that goes beyond all the things that we said before and actually focuses on the implementability of these tools. In the last slide, I'll just quickly say what we're going to do next on ALPS cluster when we're ready to go. So we're going to be scaling up our models in terms of data, in terms of size, with the 405, Llama as well, multimodal, multilingual implementations, and also to make a new model that we've actually just launched in ICRC this week on Monday, which is extremely exciting, taking a massive corpus of international humanitarian rights law and using the move actually to evaluate it as well with lawyers, to take case law from war crime tribunals and genocide tribunals as well, and from Amnesty International, a massive corpus, so that they can use this to understand their enormous archives and look for war crimes and missing persons there as well. The most important slide, of course, is this one. There's not enough space to thank everyone that is on the slide, but I would like to highlight a few things. That this is a student-led initiative. It's important for sustainability, and indeed our technical lead, Alexandre Salinas, is a master's student. And we have co-created this with many people, mostly doctors, humanitarian aid organizations, and I'm very grateful to everyone who has participated. So I hope that if any of you are interested, you also would be reaching out to me to join. Thank you. Yeah.